Podcast. I'm your host, Dr. Spencer Nadolsky, and with me today, I have a former classmate, although she graduated a year before me, Dr. Kate Varney, who's the director of obesity medicine at UVA. I went to UNC, so we're kind of rivals a little bit, but that's okay. So Dr. Kate Varney and I chat a little bit on Twitter. She's one of my tweeter buddies. And we kind of lament the issues we see on social media regarding obesity. And today we're going to be talking about this false dichotomy between obesity being genetic versus all environmental, and some of the nuances there with willpower, discipline, and all that type of stuff. So welcome to the podcast, Dr. Varney.
Thanks for having me.
Yeah, so we were just kind of chatting offline before we got on about how strong of a role genetics play, but of course, environment plays a role. How do you kind of talk to patients about this, and how do you kind of go about it on social media? Because nobody really likes nuance. They like black and white. That's what gets the views and likes and shares.
Yeah. And it's funny. I think genetics is particularly a triggering topic for people. You never really hear people that discuss genetics deny the environmental factor. But the people that just really want to deny the genetics, they are just like stone cold, like they will not hear it, they're all about environment and they do not want to hear about the genetics at all, and whereas we are like, no, it's both. Right. And
yes,
you can't be dismissive of the genetics and not deny that there is some influence of the environment and the genes and how they play. And kind of what we were talking about before is, unfortunately, the people that we hear the most deny genetics and even as if that obesity is a disease in general, are the ones with the loudest voices and this biggest platform in social media. And they have just enough information to make them sound credible. But I think it confuses patients. You've seen this recently with Bill Maher and Joe Rogan talking about, and one of the things they say is, did we just evolve in the last 50
right.
years? And I think the most important thing that I try to relay to patients is that, okay, you have to first understand that there's genetics, and then there's genetic mutations, and then there's epigenetics. Right?
Yeah.
So genetics don't change, right? You cannot change your genetics. I cannot change the fact that my genes, that I have brown eyes and that my pee is smelly when I eat asparagus.
Unless we get that CRISPR, right? We can get our genetics changed with a CRISPR thing now, but for the most part, yes.
Right. But epigenetics can change within each generation, and this changes through something we call DNA methylation and histone modification. And these changes impact the expression of our genes and how they're playing in the environment. And kind of the analogy I use with my patients is I say, think of your genes as like a highway with a lot of different exits, right? And epigenetics are like the road signs that are leading you to take different roads and different exits, right? And so, if there's a roadblock because of a flood, the signs adjust in order to kind of guide the traffic, around to navigate that environment that you're in. And sometimes it's a really effective, and you end up on a road that's really effective and your body thrives in that. But sometimes you end up on a road where, it's a really bumpy, dirty road, and our bodies don't respond well. And this is what we're seeing with the epigenetics of obesity, is that, our body is not responding well to the environment that we're in.
Yeah. I mean, so we can go over quickly a little bit about the genetic. There's monogenic mutations, and there's polygenic. Monogenic, like you said, we were talking before this, but you see it: childhood hyperphagia, lots of eating, extreme severe obesity, early onset. These are some of these big mutations in the brain, downstream in your brain, that control our eating behavior. But then there's polygenic, is what we see mostly. It's just little variations in our genes. But honestly, like you said, if everything were just determined by genetics, then who cares about behavior? Who cares about our environment? And we're not saying that. It's just that these genetics can kind of push you towards one way versus the other. depending on your genetics. And there's some people protected from obesity. So this is the claim. This is what I always say on social media. If genetics weren't an issue, there are some people that don't even try to be lean, that don't care about their nutrition or exercise. Yet, despite this current obesogenic environment, they're protected from it. So, are they choosing to just be lean? And no, they're not. They're just going through life the way they are. So, it's kind of I like your analogy there with the highways and getting off, because how our genes are expressed change based on our environment and our behaviors, and that's kind of depicted through the epigenetics. I like that analogy.
So we have a researcher here at the University of Virginia, Dr. Eileen O'Rourke, and she examined over 293 different genes that are associated with obesity in humans. And she actually identified 14 genes that actually caused obesity and 3 that protected us against obesity. And this is where you're talking about, like, I see some people that eat total like crap, right? But they're still lean. I'm like, I
Yeah,
go off
what gives?
weekend and I'm like gaining 5 pounds here. But what she did, and the way she proved this, especially with the ones protected, so she took the genes that protected people from, or protected the mice from obesity, and she knocked them out. So you can, kind of get rid of them. So she knocked them out, and then she fed them a diet of high fructose corn, like corn syrup chow. And that's what they call the stuff they feed the mice as. So she fed them the high fructose corn chow, and they gained weight. But the ones where she didn't knock out the genes, she said she fed them the same high fructose corn chow, and they didn't gain weight. So therefore, this is always, we identify the genes, and then we have to test it in mammalian models, and then
Yep.
test it in humans, right? And this is how medicine evolves. And I always tell my patients, I say, anything I'm saying today, let me just premise that in 1 year I can be completely wrong, because this is how rapidly obesity medicine is changing and what we know about obesity. And thank goodness there's all this research going toward this. And I think, shaming people for using medications that are, for these people that have dysregulation in their metabolism is like kind of, saying, well, when I rode a bike 50 years ago, I didn't have a bike lane and I got, clipped all the time. So like, why should you have a bike lane?
Yeah.
Right. Right. So you're denying these advances in medicine, but it's a way to help people that, to level the playing field for people.
I always like to say, like when they post that online, I'm like, posted from your iPhone, which is like literally a more powerful computer than anybody had when we were like younger. It's such a
Right.
people love that. Just being hypocritical of their life's current lifestyle. What you talked about the mice, there are many mechanisms by which people can develop obesity. We talk about energy balance, the calories in versus calories out. A lot of nuance in there, but in general, from what I understand of the literature, a lot of the genes related to obesity are centrally located in the central nervous system that are related to appetite. And that obviously, if your appetite is dysregulated, especially in this current environment, whereas before, if you're just surrounded by whatever, let's just say lean protein and more whole types of foods, you may be a little bit heavier than your peers. But now with this current environment where it's like, I don't know, like just I'm looking at goldfish and whatever, just super highly processed, ultra processed foods where we already have a trouble regulating that. If you have genetics that are slightly different from someone else who might be leaner, you'll have an exacerbation or augmentation of that energy intake. So imagine someone, if in the 50s, people didn't have obesity back then. Well, that same person might have been a little bit heavier back then, but now with this current environment, with the already dysregulated types of food that are trying to go past our wiring system, the wiring system's already slightly off relative to someone else. And just, you see, that's where you start seeing catapults in our weight.
Right. So it's like, yes, like no Bill Maher, like our genes did not change that much, in 50 years.
No, right.
But what did change is that it's huge. I mean, you can see it from what, my parents ate and the restaurants that surrounded them. And, kind of in the last 50 years, our environment has changed so much. And it's not just what we're eating, it's how we interact with the environment. Like, we're much more sedentary, right? With our jobs, we rely on our cars more, we're not as active. It's only been in the last 50 to 75 years that we've been importing fruit from South America year round, right? So, like, we didn't have access to, fruit year round. We ate 3 square meals a day and we didn't snack. The snacking industry really kind of boomed in the 1980s. I was born in the 70s, and so, like, it was like we didn't snack. If you snack, you ruin your meals and your appetite. And I remember, like we might get goldfish in a little cup of water at Sunday school, kind of thing. But, like, we didn't snack. Whereas now, they want to feed my
It's
kids all day long.
snacking all day long.
Yeah, when my kid went to kindergarten, I didn't send a snack, even though they kind of said to send a snack, even in some of the papers. And I got a little bright paper letter saying, your child did not have a snack today. Please send a snack so they can have, plenty of energy to make it through their morning. And I was like, have you met my child? My child has plenty of energy. They do not need a snack. It's like they're
Yeah.
just like at a trough all day long, just eating, eating, eating. And, we didn't have, when you look at the foods that were on the dinner table 50 and 60 years ago, we didn't have really highly processed food. We ate at home more. We didn't have, gas stations with full service restaurants that were passing by going, I'm headed home toward dinner, but, like, I'm kind of hungry, so I'm going to stop off and get a bag of chips.
Yep.
So it's like, do we need to eat less and exercise more to lose weight? Absolutely. We absolutely do. But when you don't have those, like you said, central nervous system, the hypothalamus, the arcuate nucleus, all of those, the regulation of leptin, ghrelin, GLP, GIP, when you don't have the proper level and signaling of that, of those hormones and neurochemicals, then it makes it very difficult to not get into that and want to eat these, like, highly processed, tasty foods, right?
Yeah.
You can't deny they're really tasty. So,
Yeah. So you see some of these people where they're eating whatever they want. If you look closely, a lot of these people, they self-regulate without even knowing. They may eat whatever they want, but it's not as much as you probably think. And throughout the day, they might be eating a lot less at other times too. It's really interesting stuff. And then actually sometimes people are protected because they kind of interesting. They actually don't absorb as much. Some interesting genetics where they poop it out. It's really,
right,
really, really interesting stuff. So it's like, oh yeah, that person clearly has discipline. It's like, no, they're just genetically protected. And also, I think it's really important for us to say that, like, just because some people have a genetic propensity, and now I'm not talking about one of these monogenic deletions where it's like severe childhood hyperphagia, severe obesity. It's, maybe polygenic where multiple genes look like they kind of push someone in one direction. It's not determinist. Like, it's not going to determine no matter what that they're going to develop obesity. It's that they have a higher likelihood, but it doesn't mean that they're going to actually go that route. And so there is the ability to prevent it. There is ability to treat it, especially now that we have GLP-1s, but also behavior wise, even when we're younger and trying to set up that micro environment. It's just hard because we can't control the macro environment, can't control the gas stations and fast food places that are surround us. Or I always say the person in the workroom bringing in the donuts, and at the ER bringing in the pizza for everybody, or wherever you're stationed at. So I think you probably tell your patients that too. It doesn't determine exactly what your weight's very multifactorial, as you said
right. I mean,
before.
it would be the same as, like, someone with substance abuse disorder or alcohol use disorder. I know patients that have, strong family histories of alcohol use disorder, but they avoid alcohol,
Yeah,
right? And so, but, the urges are still there, and they still have, like, kind of compulsive behaviors to try to, like, soothe with other things, kind of thing. So, you know, it's like, I think they say 7% of childhood severe obesity, it's genetic. Like,
yeah,
and nobody denies that. but there's just such this, denial that there is this genetic component for adults. It's still, we're still looking at it as, somehow it's, willpower. And I tell my patients, I go, willpower is a made up thing that people say to make them feel really good about themselves, I guess, because willpower is nothing but a combination of neurochemicals and hormones. And thankfully, we have medications now that can help regulate some of that hormone dysregulation, like with the GLP-1s, the GLP-1 receptor agonists. And how do they work? We know they work in a lot of different ways. One of the big companies, I won't say their name, but they're actually studying, and they're not only they're showing that these medications work even beyond the caloric reduction. But they do work partly because it causes a caloric reduction and they lose weight that way. But there's also the glucose insulin, kind of regulation that it helps with. And they're starting to see in studies that people, if you feed them cut the calories the same amount with the people on the medication versus not, that the people on the medication are still losing more than they would expect than just from the reduction of caloric intake. So.
Yeah, I think we're going to see some really cool stuff with the upcoming drugs coming out. There's some drugs that increase muscle mass and decrease fat without appetite changes. There's obviously the glucagon component they're going to put on that decreases or increases metabolic rate, decreases liver fat, and all sorts of stuff. The future is bright. And, for those who feel like they were doomed because their genetics, have some hope. So thank you so much for coming on the podcast. For anybody that wants an awesome doctor that lives in the Charlottesville area, I don't know if she'll take your insurance, but you can check it out at go see Dr. Varney as the obesity director at UVA. Thanks for coming on.
Thanks for having me.